Endocrinologist in Austin, Texas, and I'm at a practice called Texas Diabetes and Endocrinology. I'll say here in Austin. We have 3 offices, if you know Austin, and North, Middle, South, Round Rock, and South Austin. And I'm a boarded endocrinologist. That's what I do: cardiometabolic, diabetes, all those things, pretty much all day long. And what I'm going to do today is I'm going to talk about and review some things we talked about before. I'm going to talk about tirzepatide. Now, what in the heck is tirzepatide? Well, tirzepatide is Mounjaro, and that is that new medicine that got approved really very recently. It's an Eli Lilly medicine. So Mounjaro is spelled Mounjaro, but it's pronounced Mounjaro. And so that's the drug name is tirzepatide, and you know that's not going to be easy to spell at all. Tirzepatide, and it's the first in a new class of medicines. It is a new class, and I'll explain that a little bit. So I'm going to break this talk into a few different parts. We're going to talk about tirzepatide, and we're going to talk about how it works. We're going to talk about the diabetes data, and then I'm going to talk about some really interesting obesity information that's come through. So first in class of new diabetes medicines, but what about that weight loss? Whoa, we're going to talk about that. And first I want to talk about how tirzepatide or Mounjaro works. Now, first of all, it's a single molecule. That's one thing that's really important. It's not some double hook molecule. It's not something that kind of two things stuck together. It's based on GIP. And I'm going to use some terms, I apologize, but I'm going to define them. And GIP is glucose dependent insulinotropic polypeptide, and so now you understand why you want to say GIP and not that. I mean, who would want to say that? And you know GLP-1 is glucagon-like peptide 1, and we've been using meds, they're GLP-1 meds for a while, like Ozempic, Trulicity. They're weeklies, and they're working for us very well, and we use a lot for diabetes. And then you know that Ozempic is approved, it's semaglutide, and it's approved as that drug called Wegovy that's used for overweight, for obesity management. So, new world here, and this adds yet another twist to the new world. So it is a new drug class because it has GIP and GLP-1 like effect in one molecule, and it's actually novel, and it's a peptide, and it's engineered. And it has, if you're interested in, if you like to talk about amino acids, this one has 39 amino acids, and has what's called a fatty diacid moiety. Don't remember that. And it has a half-life of about 5 days, and so it can be given once a week. That's pretty nice. And it's an injection. It's liquid. It doesn't have to be reconstituted, and it doesn't have to be adjusted to renal or hepatic impairment. It's not metabolized there. It's kind of nice too. You don't have to worry about that when you're using it. So that's kind of a little bit about what I want to tell you about it. It agonizes, it does agonize the GLP-1 receptors in the body, and it agonizes the GIP receptors. And you may say, again, you know, GIP, glucose-dependent insulinotropic polypeptide. It twists my tongue too. Well, what is this about? Well, GIP receptors are on the beta cells, and they actually agonize insulin production. So let me talk about what these two different receptors do. This is one molecule. That's why I said that, 2 molecules, see if you're awake and see if you're paying attention there. It's one molecule. Well, what GLP-1 does, and we've known this for a while, it reduces appetite, increases satiety, slows down gastric emptying, and actually stimulates insulin production. That's GLP-1. Remember that, GLP-1, glucagon-like peptide 1. That's what these. Remember, that's Ozempic, Trulicity, Bydureon, all those. That's what they are. They're GLP-1 only drugs, and they lower glucagon, and they actually lower glucagon. Why would that be important? Well, because glucagon stimulates hepatic glucose output, which raises glucose, and you want it to be suppressed in people with diabetes, especially after they eat. So GLP-1, we know a lot about GLP-1. What about GIP? Well, GIP probably does also have some central appetite effect, and also may reduce body weight in and of itself. There's some data that says that GIP And remember, we're talking about tirzepatide. I'm just going to focus again. Tirzepatide, now called Mounjaro, actually has effects on both GIP and GLP-1. And the GIP part makes it very unique. Well, so again, GIP, lower body weight, it does increase insulin. We know that very, very well. It may have some really good effect on insulin sensitivity in the adipose tissue and perhaps muscle too. That is interesting. Think about that. So now we have a drug that does all those things we talked about already, the GLP-1 effects, and we have a drug that magnifies insulin production and increases insulin sensitivity, and both in the fat and probably also both in the muscle as well. So of course, what is that going to do? It's going to lower glucose, might help lower weight. Well, we're going to take a look at some of the data in a minute. Would you see more weight loss with this two dual effect drug, or not? And well, we're going to find out more about that. So that's kind of the tirzepatide Mounjaro, what it is, what it does, and what it should do at least. And we're going to talk about what it does here in a minute. All right, so let's talk about the data that got it approved for treating diabetes. Let's talk about the data that got tirzepatide. Mounjaro is the company name. Of course, talk about the data that got it approved. Well, I'm going to make short work of this, but I'll tell you there were 5 different trials that were done in people with diabetes. Of course, the approval right now is diabetes. Do we hope it's going to get an obesity approval? Well, I'm going to ask you about that. We're going to look at the data here in a minute. And so diabetes, these trials, every company comes up with a name for their trials, and in this case it's the SURPASS trials, SURPASS 1, 2, 3, 4, and 5. There's one called 6, 2, and I'm not going to say anything about it because it's not published, but the SURPASS 6 trial is the one that is going to look at cardiovascular outcomes. And you know that every drug has to have a cardiovascular outcomes trial. We don't have it yet. It's too early for tirzepatide or Mounjaro. So SURPASS 1 is give the medicine in addition to diet and compare it to placebo diet. SURPASS 2 is give the drug and then compare it to one of the really good GLP-1 meds, Ozempic. SURPASS 3 is compare it to tirzepatide as initial, that's the basal insulin, that. The basal insulin is first injectable. So either people on orals get the tirzepatide Mounjaro, or they get tirzepatide as initial injectable. And then there's a trial that compares it to Lantus as first injectable, or Glargine, and then there's a trial, and that's the SURPASS 5, that actually gives it in addition to insulin. So it's been studied in pretty much every scenario. And let me just tell you, make a long story short, do we want to go through all 5 of those trials? Oh, we do, but we don't. It would take too much time. I'd love to. But actually, what happens here is you take people with A1Cs in the mid-8s, and in the SURPASS 2 trial, for example, these are people who are on metformin alone and diet, and they're given either Mounjaro 5, 10, or 15, and those are doses that we can use compared to Ozempic. Now, they didn't have the Ozempic 2 milligram, that's the new higher dose, but they had the 1 when they did the study. So you compare all those different doses added to the metformin, baseline A1C 8.3. What would you hope for if you add one medicine on top of metformin, and if the A1C is 8.3? Just you can answer yourself what. I see a question. There's no evidence for teratogenicity. We don't have any data on PCO either, but we have data on diabetes, and that's about it right now. And so what happens if you add it? Well, it turns out that the A1C reductions were like 2, 2.2, 2.3 at the 3 different doses, 5, 10, 15. Think about that. Most of the time, most people tell me they'd be happy with a 1-point drop. We're getting to 2.3, and that's really pretty good. And in the group that was given Ozempic, the drop was also very good at 1.9. And so that is the bottom line there. And so the rest of the trials showed very similar results. So really, really good drops in the A1C. This is going to be a very interesting diabetes drug. We know that. But then if you go on and take a look at some of the other information, and I'll tell you right now, when we record this later, we're going to throw some of the slides in the background. I'm not going to be talking slides right now, but you'll see the data if you come back to it and replay it. I'm going to put some of this up there, but I'm giving this to you verbally right now, completely verbally. And so what about the weight? What do you think is going to happen there? Well, I mean, how many pounds would you be happy with? Well, it turns out that the weight loss was quite substantial. And if you look at percent body weight lost, we'd be happy with 5% body weight loss, right? From baseline, we'd be happy. That helps everything. But in one of the trials, we're going to go back to that SURPASS-2 when you add it to metformin, and people weighed about 200 pounds. They lost up to, the people that were on the 10 milligram dose lost about 9-point-something% of their body weight, 9-point-something%. And the people on the higher dose, the 15, lost 11.2%. And that was superior in that case to the comparator. And really, when you look across the board in those trials, people are losing up to 10, maybe more percent of their body weight. This is mean, and I don't mean like mean. I mean mean losses. And I'm gonna glance over. I have some information to the side here that we might be able to display when we put up the slides later. But actually, if you ask what percent of people on the 15 milligram lost greater than or equal to 15% of their body weight, 15%, think about that. Along with these improvements in the glucose, it was 36% lost that much. And another really interesting outcome, it was an income too, but in one of the studies was if you look at the percent of people that had an A1C less than or equal to 6.5, like really good, also had a weight loss of greater than or equal to 10%, fabulous, and no significant hypoglycemia. Guess what percent that would be if you had the percent of people on the 15 milligram that got all three of those outcomes. Well, it was 60%. 60% of people had the A1C, the weight loss that was over 10%, and then no significant hypoglycemia. This is going to be a fun drug to use, and it's going to be really great for our patients, and that's what it's all about. And one study showed that weight loss was sustained. The SURPASS-4, which compared to insulin glargine, showed that the weight loss persisted for up to 2 years. So we do have longer-term data. It's not like it goes down like a Nike swoosh and then back up. It stayed down. So that's really good. And it turns out that we can slice and dice this about 100 ways, but about 59% of people in the tirzepatide on the tirzepatide in the trials lost greater than or equal to 10% of their body weight. So I'm not going to go any further there. I'm going to talk a little bit about side effects a little bit later, but the diabetes data looks really strong. So in summary, for this first part of the talk, tirzepatide is this one molecule, new class of drug, has a dual GIP and GLP-1-like effect. We've defined that, and these activities are probably at least complementary. They may be synergistic, and when it comes to various outcomes, including weight, and so we saw really robust reductions in A1C. So now what I'm going to do, that's the diabetes, and that's the approval. We have approval for treating people with diabetes type 2, not PD, not type 1, type 2, with this agent. But what I'd like to do now is go ahead and talk about something that's not indicated for yet, and that is treatment of obesity. And so you may know, and you may have read, and I'll just show you if you didn't, just to prove it, in New England Journal in July of this year, just a few weeks ago, there was a publication that looked at tirzepatide. You probably can't see that very well, but I'm not really intending to see it here. I'll flatten it out a little bit. Tirzepatide treating people just for obesity, and not specifically for diabetes, but for obesity. And I'm going to talk a little bit about that. That data is out. It's available. There's no approval at this point. But where do we go with this agent? Well, I think we go that direction. Now, the trials, and again, we're going to put up slides later, and if you want to come back and review this, you'll get me, talking about what I'm talking about right now with slides in the background. We didn't do that this time. I didn't want to distract you on Saturday morning. It's a little much to take on a Saturday morning, and so the weight loss trials, the pure weight loss trials. Now we're get away from diabetes. We're going to talk about pure weight loss trials. We're SURMOUNT 1, 2, 3, and 4. And the Surmount 1 is the one that was just obesity management. There is a trial, though, that's going to be done in people with type 2 for just obesity management and also blood sugar control. And then there's some others that are on the way too. And so let's move on and talk about the Surmount 1. And that's the one that got published as well. So in Surmount 1, basically you take people who are overweight, and I'll tell you more about the criteria in a minute, and you put them on the 5, 10, or 15. Now you start at 2.5, remember, and you make your way up to 5, 7.5, 10, 12.5, and then 15. That's what you do. And you take it up very, very gradually. And so, and then this study goes on for a good well over a year, and then compared to placebo. Everybody got very, very thorough diet education and, lower your calorie education. To get in the study, you had to have a BMI over 30 or over 27 if a person had comorbidities, and those included dyslipidemia, hypertension. They could have prediabetes, and they could have obstructive sleep apnea, and they could have cardiovascular disease too. They couldn't get in if they're going to have a surgery for obesity or if they had type 1. And one thing I want to tell you, if the demographics, when you look at the article, this is a well sort of recruited trial, and the average age was about 47, number one, about 69% overall female, and that's true of most of the trials. As far as racial sort of mix, white was about 80%, black or African American about 14%, and then Asian, and there was Hispanic was about 26%. So this is actually a very fairly representative trial of the population, and the average weight at the time of entry was 104 kilos. And let's see what else we want to talk about. Prediabetes. Yeah, about 40% of people did have prediabetes, and we're going to get a look at what happens with them. And I'm going to go through that in kind of a macro, really. Blood pressures were actually in pretty good shape. The people were on medicine. And so let me just jump into results. So you organize this trial. You bring people in that are overweight. They don't have diabetes, but they have comorbidities. They can have prediabetes. And you put them on one of the 3 doses versus placebo. And again, the placebo people did get dietary counseling. They just weren't left to their own and say, hey, go out there. They got some encouragement. Well, what do you think was seen as far as weight loss goes and I'm going to talk percent weight loss of the original body weight, and I'm also going to talk about weight in pounds. So what do you think was seen over 72 weeks? So this was fundamentally a 72-week study. Well, actually, I'm going to talk about on treatment. Some people did drop off. A low percentage of people did drop off. Some because of GI side effects, and that's going to be something we're going to have to keep an eye on with this drug and any drug. All right. So what do you think? Somebody can put a note up there. What percent body weight loss did you think you might see at 72 weeks at the highest dose? Somebody put a percent. Give me a guess. Okay, well, I'm going to jump on in and let you know. At the lowest dose, 16%. Placebo people lost 2.4%. You know, that placebo effect's not bad. But the people on 5 milligrams, 16%, and the people on the highest dose, 22.5%. That's percent. That's not pounds. That's percent. Think about it, percent. And what would you be happy with when you tell people, I want you to lose some weight? I'm ecstatic with 5%. 7%, 10%, I am just bowled over. 22.9% at 72 weeks. Now, how does that translate in terms of pounds? Well, you can tell me. Remember, the kilo thing was about 100 and something, 102, I think I said, kilos at baseline on mean. Well, the people at the highest dose lost on average about 50 pounds. The people in 10 lost about 40 something, and mid 30s for the 5. I mean, that's just something else. And that was and so the average weight reduction, depending on the dose, was 35 to 52 pounds. So it depends on the dose, and the highest dose people lost more. Now, what about percent of people reaching their target? About 90% plus people lost more than 5%. That's one thing. Okay, so that's good. And we've always been really happy with that. About half of the people that were in the weight loss part lost more than 20%. And we can cut this all different kinds of ways. About 1/3 of people got greater than 25% of their body weight loss, at the original body weight. And so, we can slice and dice this in 5 different directions. And it turns out that you might ask, well, what percentage of people actually responded? People ask that question. I do too. And what percent of people actually responded? It was 97.7%. So very, very low percentage of people didn't respond or didn't lose weight. So that weight loss data is robust. So I'm going to shift gears here a little bit. And so we talked about the data. And please, take a look at that New England Journal article. I'm not sure if it's open, free online or not, but you could find out. And that is substantial. And I'm going to ask you, I'm going to ask myself too, what does that mean? And let's put some perspective on that in a bit. But before we do, let's talk a little bit about, we've seen the weight loss. We're talking about the weight loss trial only. We're not talking, we're not talking about the diabetes side. We already talked about that. Go back and listen to that again. If you came on late, we talked about diabetes and the approval. We talked about that earlier. And if you came on late, I'm going to tell you also, we're going to put the slides up a little bit later. And you get to look at the blinds behind me, but not the slides right now. And we'll put them up later. But what about improvement in metabolic measures? Okay, so people lose weight. We know that confers great benefit. Well, let's talk about the metabolic changes. And I'm just going to go through this. Again, I'm verbalizing this. I'm not going to show you the pictures right now. But if you look at body fat mass loss, we're talking about mean. This is a subgroup of people, about 160 people, who actually had DEXA body composition. It wasn't everyone. And the people on treatment, there was about a 33.9% fat loss. And then what about hemoglobin A1C? Well, remember, they didn't have diabetes, but they could have prediabetes, and they had A1Cs. And A1C reductions were like 0.4 up to 0.5 from a low to the high dose. So reduction in A1C was seen. And this is, okay, what about glucose, fasting glucose? Well, duh. If you lose weight, you're going to see the fasting glucose drop, right? Well, it's important to see numbers. We want numbers, we want data, and we want science. Well, the numbers are the fasting glucose dropped and dropped substantially, 7 up to 10 points. And the baseline glucose in this group was 95. Remember, this is not a group of people with diabetes. So there was kind of a pretty close to an average decrease in fasting glucose of 10 milligrams per deciliter. And again, focus, this is not a group of people with diabetes. You're not going to see like a 30 or 40 point drop as you do see in the people with diabetes. These are people that have either normal glucose tolerance, 40%, as I mentioned earlier, have prediabetes. And again, we're talking about the SURMOUNT-1 trial that was published in the New England Journal, in case you came on late. Now, insulin levels dropped also. Like another duh. If you lose weight, the insulin levels fasting are going to drop, and they drop down about 4 or 5 milliunits per liter, and that's good. So less insulin resistance, and the percent change there was about 47%. With tirzepatide, because remember, insulin levels don't necessarily have to be real high in people who don't have diabetes. What about change in lipids? Well, we see what we thought we would see. You lose weight, your triglycerides drop, and that definitely happened. 27% decrease in triglycerides. That's pretty good. That's on par. It may even be better than the drop we see with some of the medicines we use for triglycerides, depending on the baseline triglyceride too. And so the HDL went up about 7.9 points, and so free fatty acids dropped. What else do you want to know? LDL dropped about 6.9, and that kind of covers the territory. No surprise. Metabolic. This is a cardiometabolic drug, and change in liver enzymes, fatty liver, all that. Well, there was an improvement there too, and the decrease in liver enzymes information has to be explored further, because would this be a drug for fatty liver? We don't know. Do we think it could be? Oh yeah, we do. We do. this we does. But I mean, I'm not representing anyone but myself here. But you know, if you lose weight, fatty liver gets better. I think it's safe to say. Systolic blood pressure, there were reductions there of 4 or 5 points. Reductions also in diastolic, and so that's also no surprise. And remember, these weren't people with really high pressures to begin with. They're like 123 systolic, and diastolic was about 79. So if you drop 3 millimeters of mercury, systolic, diastolic, that's actually a pretty nice drop. So the summary of efficacy results would be that weight reduction leads to significant improvements in multiple metabolic parameters, as you would expect. And so that's actually a really big deal. A fairly high percentage of people actually converted from prediabetes to normal glucose tolerance too, and so that's also really interesting, I think. So is it going to be approved for prediabetes? I don't think so. But is it going to be approved for obesity? I frankly think, based on this trial, and hopefully there'll be another trial that says the same thing soon. And do I think it's going to get approved for obesity management? Yes, I do. Do I think it needs to hurry up? Yep. And so you know, let everybody know about that wonders. And the weight reduction was actually sustained over 72 weeks. We want to see longer term data, but you don't see any kind of inflection up out to 72 weeks at all here. And will it maintain without the drug? I don't think so. Are you going to need to continue taking the drug to keep the weight loss? I think so, don't you? But anyway, it's really interesting, the data that we have here. And all of the metabolic parameters got better. Let's then finally talk about side effects, and then we'll close, and I'll take a few questions. Well, the side effects, what are they going to be? They're going to be GI, nausea, vomiting, diarrhea, constipation, and there will be a dose-related effect there. The higher the dose, the greater the effect. Does that make people discontinue? Some of people did. A low percentage of people discontinued because of GI side effects. But you know, just let your patients know. The nausea, the vomiting, most of those effects tend to be early on, and they tend to improve over time, but not always. And if you look at the data, the nausea was greatest in the first few weeks, and then it tended to reduce, even though the doses were going up. Remember, you start with 2.5 on the diabetes side, and it was done on the obesity side too. You start at 2.5, and then you move the dose up as you need to, and as is tolerated. And actually discontinuation rate because of GI side effects was, let me take a look here, what was it? 0.5 placebo, and it was 1.9% at 5 milligrams, 4.4 at 10, and then 4.1 at the 15. Other side effects, mainly GI, and that's going to be it. But what else? Well, hair loss, dizziness, injection site reaction. When people lose weight, they get hair loss. It always gets better. Dizziness could be caused by blood pressure drops and orthostatic. You know, you may have to reduce the blood pressure meds when people lose weight, as you well know. So let me finish. You've been very patient. You've hung in there for a bit of time here this morning on Saturday morning. And so let me just give some perspective briefly. I've kind of given it throughout, and you have your own perspective, I know already. And I think, first of all, tirzepatide, Mounjaro is what it's called for diabetes, is an effective addition to our diabetes treatment armamentarium. And we've sent quite a few prescriptions out and related to diabetes, and it has a really good weight effect in people with diabetes. You know, that percent, 10%, 15%, some people achieve that with this drug. You've got to watch out for the GI side effects for sure. It has that notable effect on weight loss in people who don't have diabetes. And now, when I look at the data, what in my mind, what does it look like when I see that kind of weight loss? And when you look at it, what does it look like? I mean, and I don't want to overstate this because I just want to, you know, be as factual as possible. But you know, it kind of looks a little bit like bariatric surgery, and so we're just going to have to find out where we go here. And we know that it reduces cardiometabolic risk. we are waiting for the cardiovascular outcomes trial, and I'm not going to guess what it's going to show, but I'm hopeful, and we speaking of hope, we're hoping for an approval for weight loss as soon as possible too, and we know that cost is going to be a factor, always, and that's not going to change, and I think that once it gets approved for weight loss, the costs will be improved because it'll get covered. We know that. Now we're getting some coverage with diabetes too. We're getting our feet wet with that. So thank you very much for your time, and thanks for watching this presentation on cardiovisual, and please look at the cardiovisual app for other updates, and I'm of course Tom Blevins again, just to kind of close, talking about tirzepatide, the new agent which is called Mounjaro for diabetes. And we talked about the tirzepatide data that came out in New England Journal a few weeks ago, and we talked about the SURMOUNT-1 trial, and really fascinating information in the weight loss area. And there, let me just show this. There's see all those bars down and all that information. It's all there, and we're going to put this up on slides too later. And so come back if you want to look at them. And please take a look at other topics on the cardiovisual app that I participated in, and many other people too. So thank you. I'll close and I'll open for questions. And let me see what questions we have. Zach is putting together a list of a few questions that have come across. One question I got, and I just want to be really clear, because I know that some of you came at different times on the presentation, and somebody asked me if it's approved for weight loss, and the answer is no. Is it approved for treating prediabetes? And the answer is no. And will it be? I don't know. But if most people who have prediabetes are going to be overweight, and if you get an obesity indication, then likely there'll be coverage for many people. So we're waiting for that. And that's one question I got. Another question I got is there any information on polycystic ovarian condition? And the answer is, it's a great question, because those people are overweight typically, not always, but typically overweight, and also insulin resistant, and we know that weight loss can help them reduce their insulin resistance. We think that the insulin resistance has something to do with the disease itself. And the high insulin levels might stimulate the ovaries to overproduce testosterone and all that. And so weight loss is sort of a very important part of treating PCO. Do we have an effective way to get people to lose weight with PCO? Some people do with the weight programs, and some people do with some of the other meds, but it's just challenging. Would I use this preparing someone for pregnancy, for example, as PCO? If we get an indication with the obesity, I'd be very careful. I think you could use it for up until a few weeks before. I don't think I want a person on the agent when they're working on pregnancy. During pregnancy, we don't know. There's no study looking at that, and I don't think there will be. I can tell you that in animal studies, the medicine might have some negative effects on the fetus on animal studies, so I wouldn't use it during pregnancy. And so anyway, back to PCO. Interesting question. We'd love to have a good, effective treatment for PCO, wouldn't we? Or a good way to get people to lose weight who have PCO. So we'll see. I suspect there'll be some subgroup data, or some like a investigator-initiated trial. Maybe we should do that here. I don't know. Thank you for that question. Let's see. Any other questions regarding tirzepatide? I think I see a couple more coming in. And one question is, what is the GIP receptor? What is it? Well, what is it? That was let's see if I can get you back. That was an upsetting question, I guess. I don't know. But okay, so the GIP receptor is a receptor that is definitely on beta cells, and it also is throughout the body. So the GIP receptor, this is an important receptor. It may be in the brain too. It looks like it is. And again, this receptor is clearly important when it comes to insulin production, because when we have an agonist, something that stimulates it, like the Mounjaro, tirzepatide, the drug we're talking about, then you get more insulin production from the beta cell. It looks like there's probably some GIP receptors in fat cells and also in muscle cells too that help increase insulin sensitivity. I mean, for a long time, all we talked about is insulin resistance, and when it came to managing diabetes, and then we got this new group of drugs called GLP-1s, and we started talking about other things, and now we're kind of going back around. I used to call, just to kind of characterize, I used to call GLP-1 meds the Renaissance meds in treating diabetes, because they did all those things. GLP-1. This has to be called in Renaissance Plus, I think, or something like that. So that's my best answer there. Keep an eye out for GIP. GIP, we're going to talk a lot more about it. Is the drug teratogenic? I think I sort of answered that earlier. Not that we know of. It's been studied in preclinical studies. No evidence for teratogenicity. And what are some of the side effects? We talked about that too. Really, your main side effects, and some people are not going to be able to take it. Let's face it. That's true. A lot of medicines we have, great meds, but if you can't tolerate them, you just can't tolerate them. GI, nausea, vomiting, diarrhea, constipation. I mean, it's funny when you tell people, oh, you can have diarrhea or constipation. What? But, and also, interestingly, decreased appetite is considered an adverse event too. But now, gallbladder disease might be more common in some of the studies with diabetes side, yes. And that's something to know of. Anytime people lose weight, they have a higher risk of having gallbladder problems, And so if people get really a lot of nausea, vomiting, they might get volume depleted, so be aware of that too. Watch their creatinine, especially if they have impaired renal function. That's something you want to watch. And so be careful, and have your patients are going to like this med, I think, in the diabetes side, and it's going to be real interesting to see what happens on the obesity side. I think those are the primary questions that we've gotten so far. I appreciate your attention and your time, and I think we'll go ahead and close. And thank you very much. Again, Tom Blevins speaking on the Cardiovisual app. And we're going to have more information for you and more talks as time passes. And look backwards on that app, please do. And you'll see quite a few talks that we've already generated with me and many other people in the diabetes area, the cardiometabolic area. Thank you very much. All right, we'll close.